My name is Dr. Elvis Enriquez, and I will be presenting Nasal chronic cough is pneumonia, the diagnostic value of history and early bronchoscopy and foreign body aspiration. Foreign body aspiration in adults is an uncommon event and is often overlooked since aspiration is rarely weakness. Symptoms may mimic infection or malignancy, which leads to delayed recognition. Although older adults or patients with swallowing difficulties are considered high risk, healthy young adults can present with unrecognized aspiration. Imaging can raise suspicion, but chest radiographs often fail to detect radiolucent objects. CT scans are more sensitive, however, findings are frequently non-specific. Bronchoscopy remains the gold standard because it allows both diagnosis and treatment in a single procedure. Our patient was a 39-year-old Hispanic male, a former smoker, who came to the hospital with fever, persistent cough, left-sided pleuritic pain, fatigue, and an unintentional weight loss of 15 pounds over 3 months. 2 months before admission, he developed a productive cough with intermittent upper respiratory symptoms that gradually worsened. He denied hemoptysis, malignancy, hematologic disorder, or a family history of lung disease. A chest CT without contrast showed intraluminal opacification of the left main bronchus with significant narrowing, peribronchial calcification, and mild perihilar lymphadenopathy. His chest X-ray showed a left lower lung opacity, while CT of the abdomen and pelvis was unremarkable. Laboratory studies revealed a white blood cell count of 8.1 with mild neutrophilia. Procalcitonin, ESR, and CRP were slightly elevated. Tumor markers were within normal ranges, and HIV, influenza, Legionella, and Mycoplasma testing were all negative. Bronchial wash and cultures demonstrated no growth. The patient was started on ceftriaxone and azithromycin. Hematology was consulted to exclude malignancy, which was ruled out. Pulmonology recommended bronchoscopy to evaluate the persistent lesion. Flexible bronchoscopy was performed and revealed a metallic beverage can lid embedded in granulation tissue, obstructing 90% of the left main bronchus. The foreign body was retrieved with forceps, and biopsies showed only acute inflammation without evidence of malignancy or fungal element. Immediately after removal, the patient improved significantly. He was discharged on oral antibiotics and close outpatient follow-up. This case illustrates how easily adult foreign body aspiration can be misdiagnosed. The chronic cough, fever, and weight loss in this patient strongly suggested pneumonia or malignancy, leading to a delay in diagnosis. Although imaging suggested obstruction, it was not definitive. Bronchoscopy ultimately established the diagnosis and provided curative treatment. Unrecognized foreign body aspiration may result in recurrent infections, chronic inflammation, or long-term structural damages such as bronchiectasis. Flexible bronchoscopy is generally safe and highly effective in adults, and delays in performing it with significantly increased morbidity. The key messages here is simple. Not all chronic cough is pneumonia. Foreign body aspiration must be considered in adults with persistent pulmonary symptoms, even when no aspiration history is reported. Imaging can support the diagnosis, but bronchoscopy remains essential. Early recognition and intervention can prevent complications and unnecessary morbidity. Thank you.